Now, good morning, everybody, all those who have logged in and listening to us. This IC is very pertinent and important in view that you see the pediatric ophthalmology is now almost a new sub-branch in the division of ophthalmology. And unfortunately, this pediatric ophthalmology is not developed in India. It is still very underdeveloped and understudied branch in our country. And not in our country, especially in all the developing countries. And having said that, the refractive error management, how the refractive error develops and how should be managed in children is an entirely different cup of tea. It is entirely different from an adult. How do you manage and treat an adult in the refractive errors? But in children, it is an entirely different. So, unfortunately, majority of the ophthalmologists are not doing pediatric ophthalmology. I know that, and even apart from that, the people who are doing it, they have also not undergone the basic training and the idea and the know-how how to manage a refractive error in small children. Now, I would start. It's not moving, Swapnil.
Sir, please slideshow mode.
Sorry.
Slideshow mode, full screen mode.
ऊपर से स्लाइड शो पे क्लिक कर दो.
Now it's okay. Now is it visible?
Well, it is not in slide show. नीचे आके आवर ग्लास बना हुआ है ना, वहां पे क्लिक करो. नीचे वाली लाइन में लास्ट में एक आवर ग्लास बना हुआ है.
नहीं, मेरे इसमें तो नहीं आ रहा है.
नहीं, सबसे नीचे आपके कंप्यूटर के नीचे वाली लाइन में, लैपटॉप के नीचे
नहीं तो ये ऊपर में लेफ्ट में जो करंट स्लाइड है ना, वहां पे क्लिक करिए.
मैंने स्लाइड शो, मैंने वहीं क्लिक किया स्लाइड शो पर.
करंट स्लाइड पे क्लिक कीजिए सर.
जी,
स्लाइड पे डबल क्लिक कर दो.
स्लाइड शो में फ्रॉम द बिगनिंग में क्लिक कीजिए, उसमें भी काम हो जाएगा सर.
सर स्लाइड शो में जाइए,
स्लाइड शो में जाकर के फ्रॉम द बिगनिंग में क्लिक कीजिए सर.
ये स्लाइड शो पे आ गया अंदर.
और ये फ्रॉम द बिगनिंग सर.
अच्छा, फ्रॉम द बिगनिंग.
या उससे हो जाएगा सर. थैंक यू.
नाउ इज इट देयर?
Yes.
Absolutely.
So now before we start to know the refractive errors, the status of refractive errors in children, and how do they develop, and then once you have an idea of how do they develop, then only you can manage. Now there is so you must always know the natural history of refractive errors. What is the natural history of the development of refractive errors in children and small infants? You see, the American Academy of Ophthalmology, the American Association of Pediatric Ophthalmologists, APISMAS, and the American Association of Optometry and the Royal College of Ophthalmologists of England have formulated certain guidelines for the management of refractive errors in children. That is what is important to know, and that's what we should follow. Now, for ease of understanding and measurement, the format is divided into two large groups. That is birth to 6 years and 6 years to 16 years, that is the end of the school age. Because by that time, 16 years, most of the refractive errors have developed or they have disappeared. So what actually we should also know in this series is what is emetropization. See, we always strive for emetropization, and we always want that the patient, the child, the infant should be emetrope. Now, emetropization is the process when the eye assumes a state of no refractive error. As growth of the eyeball occurs from 17 millimeters at birth to, the 20 and then 21 and then 20, around 24, by 8 years of age, the cornea flattens and the lens from almost a spherical shape becomes elliptical. The final refractive state of no error comprises of an axial length of 23.7, this is approximate, 23.7 millimeters, lens power of 21 diopters, and the corneal power of 45 diopters. So this is a standard, and the ultimate refractive state that we all should develop. Now, there is a general agreement that most infants are hyperopic at birth, and the cycloplegic refractive error is approximately 2 diopters. This is a normal concept that when the child is born up to 6 months, this is what is the refractive state a child has. Now, this hyperopia, which is transient, disappears by first year of life. So by the end of 1 year of birth, the child should have an emetropic state, at least if the hypermetropic error is only plus 2 diopters. And gradually by 3 years, it should totally disappear when the eye becomes emetrope. That's what I was telling. Though in some cases, reduction continues up to 4 years and rarely up to 12 years of life. Therefore, in cases of amblyopia or in cases where the refractive error is high, we always keep on refracting a child up to 12 years and keep him under surveillance for 12 years to see if the total refractive errors may disappear by the time. And you would start weaning the spectacles which you have given for hypermetropia. So this is one concept. There is also a higher prevalence of astigmatism at birth. Remember that, of 1 diopter or more. So this is all a natural. This is all a natural status of an infant, the refractive state of an infant when the child is born. There is also a higher prevalence of astigmatism at birth of 1 diopter or even more. All types of astigmatism are seen, which normally disappear by 4 years of life. It could be with the rule, it could be against the rule, it could be meridonial, it could be even, the double-crossed astigmatism, whatever it may be. Now, 30% of newborns also have anisometropia. That means difference of refractive errors between 2 eyes, which again disappears by 4 years of life. This transient anisometropia is due to different rates of emetropization between the 2 eyes. So, suppose in one eye there is an hypermetropia of +2, for example, and the other eye does not have any hypermetropia. It could be emetropia from birth also. It's not something unusual. So when the eye emetropizes by 1 year, 3 years, and 4 years, the rate of emetropization between the 2 eyes would be different. So when you come across such patients, you wait patiently for 4 years. If there isn't a cross, if the gross anisometropy is not there, you can patiently wait for 4 years, and then you can monitor the state of development of the refractive errors. Now, why this? So we have talked about hyperopia, we have talked about anisometropy, we have talked about astigmatism. Myopia does not exist in a newborn. Remember that. Myopia does not. If there is a myopia by birth, it is an ominous sign. It is a bad sign, and it is a sign which gives you an hint that the child is going to develop a progressive myopia, and you should. See, this is a different matter. After we can't discuss it here. It's usually done in a master class, where last year I had done it anyway. So so myopia is a nominus, is a bad sign. Be careful if you find an myopia by accident, because by 1 year or 2 years, you do not refract a child until there is a problem. So until there's a problem of, metropias or phoria, or if there is some problem, the parents bring the child usually with, tropias, because exotropia is very common in early childhood myopias. So when you get that and you accidentally see that and you do a refraction and see myopia by 2 years also or 3 years, it is not a good sign. Anyway, now why this natural history is important? With now listen carefully. This is, you can even, note it down and you can use it in your clinical practice. With hyperopic spherical equivalent of more than 5 diopters, means hyperopia per se of more than 5 diopters by 3 months of age, or greater than 3 diopters at 1 year of age. That's what is the research which they have found. There is less than 50% of chance of emetropization. That means such a child will not emetropize. And then it has repercussions. And those repercussions are that you might go into an amblyopia, you might go into a defective vision, and you might go a bilateral, ametropic amblyopia if the hypermetropia is more than that, or you may go into an esotropia. So this is what is the, the cascading effect which has if the hypermetropia does not disappear. If it is more than 5 diopters by 3 months, or more than 3 diopters at 1 age, where you should start disappearing, then there are 50% of chance that it will not disappear. Now, astigmatism of more than 3 diopters of 1 year will not completely disappear. So it has repercussions again. Infants with refractive error and strabismus have, now see, the refractive error and strabismus, it could be a congenital accommodative, or it could be a congenital esotropia, infantile esotropia, have only 50% of chance of emetropization. Similarly, if an isometropia of 3 diopters, 3 or more, persists after 1 year of age, there is a high risk of remaining at development of amblyopia. So these are the parameters which, when you come across, when you are examining a child, which may come with the child may even come with, watering of the eyes, pain in the eyes, when they start working at 3 years, or even they start playing with toys at 2 years of age or 3 years age. If the parents bring the child that there is a watering, it's an epiphora or red eye, signs of ocular asthenopia in a child, all these factors you have to keep in mind. So you cannot just, wash away these things. No, there is nothing important. You must investigate by a full cycloplegic refraction. Now, what are the implications of a persistive refractive error? Now we come to the exact management and meaning of all the topic we have today. What are the implications of a persistent refractive error which remains after 3 or 4 years of age? Because if such an error has been persisting and the emetropia has not developed or not occurred, there would be some problems in a child. And the parents would definitely bring to you, most of the parents who are educated will bring to you with some sort of symptoms. And therefore, what are the implications? You must know. Now, hyperopia. Because I have something here for hyperopia also, so with that. Now, children who maintained more than 3 diopters of hyperopia after 2 or 3 years of age were more likely to develop esotropia. Accommodative esotropia. We know that any hypermetropia of 2.5 or more, or even 2, we have seen patients even of 2 children. If they have an abnormal ACA ratio, they would even develop by 1 or 2 diopters also, they could develop esotropia. So are more likely to develop esotropia. Now, children with uncorrected bilateral high hyperopia, naturally it will come with uncorrected only. So children with, we'll put it this way, children with bilateral high hyperopia have a poor visual acuity. So I've seen many parents bringing their children who have gone to at least half a dozen ophthalmologists, who come at 5 years or 6 years, and their vision is not improving. They have signs of ocular asthenopia because they have started doing near work, and signs of ocular asthenopia, if not esotropia, at least the signs of ocular asthenopia would develop. And they do the refraction, they keep on doing the refraction, the child is not improving. The child is not improving because they have developed bilateral ametropic amblyopia and their visual acuity is poor. So that's a different subject, that how we manage amblyopia in such children. Now, studies have shown that in bilateral isometropic hyperopia, isometropic means both eyes having the same amount of hyperopia, of 4.5 diopters or more. These are all statistics. These have all been studied by pedic studies also last 2 decades. So last 2 decades, the pedic studies, what is pedic study? They have, it's a gross multi-centric studies done by the United States Strabismus Society and Pediatric Society, and they have formulated some guidelines. So this is all those studies, and we have concerns about that. So studies have shown that in bilateral isometropic hyperopia of 4 diopters or more, after 3 years, even without strabismus, 40% of children, means almost half of the children, have 612 or less of visual acuity. That means they have gone into a bilateral amblyopia. Now, poor accommodation and poor stereopsis are also associated with hyperopia naturally, because there is too much of strain put on the accommodative system. In last year in the IAGO, I have a big article. I have published a big article on accommodative anomalies in children, which so far were not studied and were not relied upon, because it was assumed that in a child the accommodation is flawless, but it is not so. There are a lot of problems with accommodative anomalies in children. So in last year's IGO, that article has been published. You can see for that. So now the point is that poor accommodation occurs in high hyperopia, and then a vicious circle starts. And there's a cascade of complaints and problems there. Now, astigmatism. Visual system is not very sensitive to astigmatism in the first year of life. We have a good heartening point here. At least we have a solace that astigmatism, which was previously supposed to be very detrimental in small children, is not so detrimental in very small children. Therefore, what it means is that the visual system is very accommodative and cooperative actually to even astigmatism by first year of life. So the visual system is not very sensitive to astigmatism in the first year of life. But after that, uncorrected astigmatism, particularly oblique astigmatism or bi-oblique, we are talking to, results in meridional amblyopia. Now, what was the cutoff? What is the cutoff line where such an amount of astigmatism would create amblyopia? And so we'll come to that later on. Now, just listen now. With every diopter increase in astigmatism, with every diopter of increase in astigmatism, there is loss of one line of visual acuity. That starts after 1 year. Also, there is loss of grating acuity, vernier acuity, contrast sensitivity, and steer acuity. This is all we see after 6 years, because before that, these hyperactivities do not develop. And therefore, after 6 years, when in later ages, when the child comes to you for examinations, or he has complaints after 10 or 12 years when he's studying and going to higher classes, all these acuities will be hampered. And these all acuities, have a bearing in the working of a child, in the studying of a child, and in the activities of a child in the school. There's a big chapter on that in many books. Now, studies also show that astigmatism of one diopter for now. See, we are now coming to the point. What I was telling you, we are coming to the cutoff line. Studies show that astigmatism of one diopter or more after 4 years of life, because by 4 years, most of the astigmatism disappears. So you have to be very, you have to be not very aggressive in treating astigmatism before 4 years, because normally the patient does not even come, a child does not come before 4 years of life. In very rare instances, which I told you before, if there is an Hyperopia or there is an ocular Astigmatism and some other problems of watering, then only the child will come to you. But then do not, for God's sake, neglect the child, because watering epiphora has many causes in children. But one of the most important, most pertinent, and most significant causes a persistent refractive error. You see, don't neglect that. Don't undermine that. You may be all be thinking that there is a problem in the NLD and NLD and LLD. No. First, take the vision and do a proper cycloplegic refractive error correction or this thing. So studies show that astigmatism more than after 4 years of life should be fully corrected to optimize visual development. That is, astigmatism normally disappears 4 years later. Now, anisometropia. See, we are talking one by one. We are taking the subjects of all the types of refractive errors one by one, which is important. Now, one diopter or more of spherical hyperopic anisometropia. Now, spherical hyperopic anisometropia, you understand what I'm saying, causes amblyopia and other relative visual disorders, which we already talked about. So now, what is the cutoff line? What is the cutoff point where we should be serious about refractive errors in children? 2 diopters or more of spherical myopic, now we are talking of anisometropy, myopic, hypermetropic, or even astigmatic. So 2 diopters or more of spherical myopic anisometry, means 0 and -2 in one eye, causes amblyopia. So this is an amblyogenic factor. Similarly, 1.5 diopters of cylindrical anisometropic, hyperopic or myopic can cause amblyopia. Of all the visual functions affected, stereoactivity is the most affected. Myopia. Bilateral isometropic myopia of less than 4 diopters up to 6 years of age is not amblyogenic. Now you see, bilateral and isometropic means myopia of the same degree in both eyes of less than 4 diopters up to 6 years of life. It's very simple. We can understand the child, before 6 years is just playing and understanding, so the visual effect does not come into the picture. Up to 6 years of life is not amblyogenic nor causes disturbance in other visual functions, because mostly the child is playing with toys and near work, so that vision is absolutely clear, absolutely crystal clear and crisp. So he does not have any complaints, neither any visual function disturbance occurs. Now, after 6 years, the child uses both near and distant vision, what I was telling you. And myopia not only hinders the visual activities, but is a stimulus risk factor for progressive myopia development. Now, antimetropia. What is antimetropia? It is not given in books, but it is there. It is now coming in vogue. One eye is hyperopic and one eye is myopic. That is antimetropia. Occurs due to unequal or disparate emetropization. Means in one eye, because of the disparate emetropization, one eye remains hyperopic, other eye may develop myopia, because because in case of the process of hematopia results in the enlargement of the eyes. We all know that from 17 to 24 millimeters. So therefore, the eye cannot shorten. That is one of the biggest thing. What is happening in in cases where the myopia is developing. This is a complex situation, and the visual disorder depends upon the degree of disparity, because there could be an amblyopia in one eye where there is hypermetropia in the one eye. I have seen at least there are four patients with me at present in my treatment whose one eye is -6 and one eye is +4. So the +4 has gone into an amblyopia. -6 we cannot give refractive correction because of the massive NIS cone it will produce, massive difference. So I am treating I have put a contact lens in one eye actually, and contact lens actually in both eyes, one hyperopic and one myopic contact lenses, and treating the amblyopic eye, the hypermetropic eye with patching. There are at least 4 still. One is already now 10 or 12 years of age, and I am now weaning off from the amblyopia treatment, but other 3 are still with me. So, this is a complex situation. You have to treat it with what I was telling you. Now, when ordering, now we have studied all this. Now we now know that what amount of these refractive errors cause which type of problems, and when we have to be serious, when we should take cognizance of this, and when you should treat them. Now we come to the other part of it, that is, when considering a spectacle prescription, the following questions should be considered before you start the treatment for these refractive errors. Now, is the refractive error within the normal range of child's age? Then it would hemetropize within 2 or 3 years of age. You don't have to worry. Will this refractive error hemetropize? We have seen that what amount of refractive error hemetropizes, and we should not be concerned. Will this error disrupt the normal visual development? Will it cause amblyopia? Will this cause a diminution of vision? Will this error disrupt? Will prescribing spectacles improve the visual function or functional vision? This is a big aspect again. There's a half of a chapter in, So will prescribing spectacles improve visual function or functional vision? Visual function is what we see, and functional vision is the vision what we have already left with us. There are so many problems in a small children, retinitis pigmentosa, bilateral Leber's atrophy, and all these things, where the functional vision is only the vision which is left with a child of 10 or 12 or 14 years is only the functional vision. So how can you improve this functional vision? So that is another aspect of discussion. It's not the time here to do it. Now will prescribing spectacles interfere with normal production of hemetropia? Again, this is now, if you start treating a hypermetropia of 3 diopters, 2 diopters at 2 years of age, only 3 years, it will disrupt the normal process of hemetropization. The hemetropization would stop there because there is no impulse or stimulus. See, hemetropization always occurs when there is an hyperopia. When there is an hyperopia, the eye always tries to compensate or contradict that hyperopia by enlargement. When this is what happens in the process of hemetropization, the eye is always enlarging in a natural course. The lens is flattening, the cornea is flattening, eye is enlarging. This is the normal process of hemetropization. So if you are too aggressive in this treatment, you might interfere with the normal process of hemetropization, and you can artificially create a refractive error which would not have occurred. You understand my point? So now, when prescription of spectacles is required, is crisp vision more important? Now this occurs in astigmatism, that the patient, the astigmatism 3 or 4, the child may not accept. But this is not always, you have to always get the 4 corrective error, because then the child would accept it. Now, will the child accept glasses at an age of 2 or 3 or 4 years of age? That is another point. Now, management. Now, there are some examples, management of hyperopia and astigmatism is more than an art. Then a science. So you have to learn by experience. Hyperopia. Hyperopia of 3 diopters or more after 3 or 4 years almost probably will not emetropize, though in some cases emetropization continues up to 10 or 12 years old. So it should not be treated or not. Yes, it should be treated. Children with symptoms of headaches, asthenopia, blurring of vision, etc. need correction in an hyperopia. So symptoms usually arise after 3-4 years of age as the near work begins. Examination of such children have shown reduced visual acuity, reduced stereoactivity, reduced night vision, contrast, that is contrast sensitivity, lack of accommodation, impaired fine motor skills, and impaired visual cognitive ability. So this if the hypermetropia 4 or more after 4 years, you remember that cutoff line, it has not improved, it can cause these problems, and therefore it should be treated and needs correction. Now, how do you correct is a matter of art. Now, how much to correct? That's what is an art. If symptoms occur before 4 years of age, because if the parents bring because of the symptoms which I had already narrated you before, correct 2/3 of hyper. If it is 4, correct 3. After 4 years, correct the full correction of hypermetropia. Symptomatic cases have been reported even with 1 diopter of hyperopia, but these are rare, and mostly in these cases there is an esotropia because of the abnormal ACA ratio. Astigmatism. I would like let me continue, okay? Because let me finish, because
Sure, sir.
okay.
Yes.
Let me finish about 10 minutes, because we have 1.5 hours. Okay.
Yes, sir.
Yeah,
No problem.
so
You can continue.
let me finish this. I'm taking all the three talks together. Okay.
I understand. Yes, sir. You can continue.
Now, astigmatism. With the rule astigmatism or against the rule astigmatism of 1.5 diopters or more should be corrected after 4 years. It means by 4 years this should disappear. All astigmatism of any type of astigmatism should disappear by 4 years of life. If this does not disappear, then you have to fully correct it. Oblique astigmatism, correct fully at any age, because meridional or oblique astigmatism or a bioblique astigmatism at any age, even if you detect it at 3 years of age, because the child usually come with that, or if there is a child comes before that because of atropia, okay, because that is the only way the parents would bring the child to a doctor, otherwise they would not know, or there would be a watering. Ocular asthenopia develops only after 3 or 4 years when the child starts working for a year. So oblique astigmatism, correct fully at any age. Myopia. This is a big area of discussion which has been going on for a long time. Myopia up to 2 diopters or more undercorrect. That has been the normal teaching. As emetropization is still occurring. See, if an myopia is less than 2 diopters, and if you correct it at 4 years, that stimulus for emetropization would disappear, and then the process of emetropization would stop there, and the myopia would progress. So, but after 4 years, correct fully. Now, correction of less than myopia of less than 1 diopter is controversial. But in my practice for many years now, I always correct even 0.75 diopters of myopia, because we do not know that what is going to be the stimulus. What is going to be the stimulus for progressive myopia? So we want to stop all stimulus for development of progression of myopia. That's why always correct full myopia, even 0.75 diopters, and isometropia. Now, after 3 or 4 years of age, correct fully anisometropia of more than 1 diopter of spherical hypermetropia, correct more than 2 diopters of myopic anisometropia, and correct more than 1.5 diopters. That means spherical hyperopic and hyperopia is more dangerous, more detrimental, is a more cause of concern because it causes amblyopia. So any hypermetropia, metropic and isometropia of more than 1 diopters after 4 years of age. Okay, 3, because if the patient comes to you early, it is 3 years of age. After 3 years, correct it fully. Myopia of more than diopters, correct fully, correct, and astigmatism of more than 1.5. So hyperopia 1, astigmatism 1.5, and myopia 2. If they persist after 4 years of age, they need correction and management and treatment. Is it clear? Now, pearls of refraction. So having said that, when you start now treating a child, who has come to you with refractive errors, and when you have now decided that this child needs treatment and correction, what are the parameters or what are the guidelines for managing this? Now, these are refract in the line of vision of a child, not parafoveal or perifoveal. Use age-appropriate cycloplegic drug. In my book, which was published by GP Brothers in 2016, there's a full book which is by the name of Correct Management of Refractive Errors and Correction of Spectacles. I have very clearly shown what the type of the cycloplegic should be used at what age. So age-specific cycloplegic drug is very important to show the full refractive error. Post-cycloplegic test is mandatory in every child. There have been cases in my practice also. I have done 6 years or 7 years child. He had some problem. Psychiatric problem. So I did not use cycloplegia. I used tropicamide, but there was a disparity in AR refraction. And when I called that child for post-cycloplegic refraction, what you called as PMT, also post-mediatric test, you can call it, or post-cycloplegic test, you call it. There was a lot of difference in what the child was accepting and what I had found in the cycloplegic refraction. So then I couldn't use the cycloplegic because of certain problems. So I used hometropine. And when I used hometropine, the actual amount of refractive error came out. So that you must always understand that if you find that with the autoraf, there is always it is not coming. It is always a disparity in each of the reading what you get it, or if there is a difference in what you have taken up, what you have found out, and in the refraction and the post-cycloplegic refraction test which you do, then you must always again do the refraction with a higher cycloplegic drug. Now, give full correction and acceptance in a child. It is mandatory that you give full correction, because that is what we want, is a crisp, good, clear vision in a child. And you will be surprised, a child even of +8 or +9 in my practice, there have been innumerable cases have after 10 or 15 days, they have fully accepted that +8 and +9. I have seen many ophthalmologists, because they come to me ultimately, or they have been referred to me by the ophthalmologist and say that the child is not accepting and the vision is not getting clear, and there are so many other problems. But when you have some patience and tell the child to keep on using glasses, and if you see after a month or 2 months, the child is so fond of glasses that as just getting up in the morning, as soon as he gets in the morning, he asks for his glasses. So acceptance is phenomenal in a small child. So don't worry about the acceptance. Don't worry about the higher refractive error correction you are giving. The child would gladly accept all the refractive, even as astigmatism of 4 or 5. That was what I was talking to you, a crisp vision and the alleviation of symptoms. So crisp vision is more important in a small child for development of his normal process of visual functions than alleviation of symptoms. And you will be surprised, You will be astonished to know that what I was telling you just now, that a child so gladly accepts all these higher numbers within span of 15 days or 1 month or 1.5 months, and our purpose is solved. Now, care in higher students, I told you, no refraction without a cycloplegia. Please, even up to 18 years, I do it even up to 21 years, do not refract, do not give spectacle correction without a cycloplegic refraction. Please, please, and please. That I have very categorically given in my book also, that there's a full chapter on cycloplegia, how to do refraction and all that. So it is published by JP Brothers. You can see it if you want, and a lot of people. Now this is what is from my book, that in what age what has to be given. We'll skip that. Now retinoscopy, as I told you, is an art. Is an art. It is, however, an art which cannot be learned from books. That's why I am here. That's why I had written that book on refractive management of refractive errors, because I know, especially it is for all ages, but it's more impetus has been given in children. Is an art which cannot be learned from books. For efficiency can only be attained. See, this is an art, so you have to become proficient in that, efficient in that, and for that it can be only attained by long, assiduous, arduous, and painstaking practice. This is from a textbook of ophthalmology, Duke Elders, about how the refraction was done, and now we have more better equipment in our armamentarium for refraction. This is an auto refractor for a small child, and and this is a photo screening. On the other photo is the photo screening. What is the mass screening we do for refractive errors? This is how the refractive. This is the fundus reflex which you get when you do a semi-dilated pupil from 1 meter, and the refraction, the fundus reflex should be equal in both eyes. That means that there is no refractive error. The Bruckner's reflex, we already know about it. How does it differ, and then how do you find out whether it is Hyperopia or the refractive error, or what type of refractive error you can get from a Bruckner? This is basically a Bruckner's reflex. You know what you're getting. So, as an indispensable aid, and this is what I'm telling you from my book, in refraction, cycloplegia should be used as follows. Now see how important cycloplegia is. Cycloplegia should be done in all children compulsorily up to 12 years of age. Number one. Manifest refraction not compatible with vision up to 21 years old. But in my practice, because I've seen with the long years of my clinical practice, that you should do it up to 20 years, because there is always a disparity. And as I told you before, the post-cycloplegic refraction, the test is not compatible with the cycloplegic. You always use a higher cycloplegic. It is important. Whenever refraction yields variable results, what I told you, if you do 10 times an autoref or with your retinoscope with streak, you find every time there is a different variable result is coming. Always use a higher cycloplegia. Symptoms of ocular asthenopia, irrespective of vision. I have done 2 theses of my postgraduates, 2 theses, and that paper has been already read in the last few AIOC conferences also, that patients coming with 6/6 vision, at least 30% of them, after doing a cycloplegic refraction, have manifested with hyperopia or hyperopic astigmatism, and that was the reason for ocular asthenopia. So you must always, in any symptom, even the vision is 6/6, because most of the time we see 6/6 and tell them that it is fine. Your headache is due to your CNS problem, or your vertebral problem, and go to that doctor, go to neurologist, go to ENT. No, for God's sake, please do a cycloplegic proper cycloplegic refraction in these patients. Now, suspected extraocular messenger, in all cases of phoria, because you are testing in a child, and if you find a phoria, even if not tropia, phoria, go for a full cycloplegic refraction. Then in infants and children where vision is difficult to assess, a lot of 2 years, with even with Allen's or even with, I have Teller's cards also with me. I try, but sometimes the child is not attentive. You do not get a correct, assessment of the vision. Then you always go for a refractive error, correction of refractive error. In repeat refraction with stronger psychologic, where astronomic symptoms continue. Number in actual or suspected ciliary spasm in children also do that. Now, atropine is very judicially used in all cases. I mean, especially I use it up to 3 years of life, not only one, but 3, but only ointment. Now, remember this thing, this is very important. 1% of atropine contains 10 milligram per ml. We all know that. What is the meaning of 1%? The meaning of 1% is 10 milligram per ml. Now listen carefully. There are 10 drops per ml. That means 1 ml. There are 10 drops per ml. That means if you put 1 drop in the eye, you are putting 1 milligram per drop, because there are 10 milligram in 1 ml, 10 drops. 1 ml contains 10 drops. So that means one drop contains 1 milligram. So 1 drop, when you are instilling in the eye of a child, you are instilling 1 milligram. Now 1 drop in each eye yield 2 milligram. 2 milligram. Okay. Now 2 milligram in each eye. Listen carefully. 2 milligram in each eye. If you put it in both eyes, it is 4 milligrams. This is 4 times the adult parenteral dose. You only give 0.4 milligram when you get an IV atropine. So this is 4 times the dose of a parenteral in an adult. Therefore, only 1 drop each eye should not be exceeded. Okay, and that's why we always say that when you block the puncta for at least 15 minutes. You block the puncta for at least 15 minutes when you are instilling an atropine drop in a child of more than 4 years. If there is a necessity, because usually I give only home atropine, is very rarely when there's a lot of cycloplegia, there's a spasm, or there's a very high hypermetropia when you see with a normal refraction. Because after 8 years, I usually give 6 years, I usually give cycloplegia, cyclopentolate or tropicamide. But when I find that it is not reacting, I go for these hypertropics. So I think I will stop here. These are certain examples which you can learn from that. I will stop here, and if there are some questions, then we'll discuss later on with these questions. Okay, thank you very much for your patient hearing. I assume and I hope that something must it must have affected you, and you'll be careful when you're managing a child with refractiveness. Thank you. Now over to you, Virendra.
Yes, thank you so much, Dr. Yogesh Shukla. It was really very fascinating listening to all the insights that you gave. Now moving to the second speaker, Dr. Virendra Garwal. You can take over, sir. You can start the screen sharing and start the presentation as well. Thank you.
Thank you, sir. It was a really overall enlightening talk, particularly for refractive errors in children. And many learnings were there. And my topic is to correct or do something to correct the refractive errors. Here, I would like to say one thing, that what you have covered is really big, extensive, and beyond something which people can think of or usually do it. But what I mean to say is that is really required thing, because most of the time what you require is that refractive error should be addressed in a very proper manner. I hope I am audible.
Yes.
Yes, sir, you are.
Thank you, sir. Though the refractive surgery is not very common, and why it is not very common, the reason is very clear. Because we are still confused what to correct, when to correct, how to correct, and what we'll be achieving. Because our aim is to give a good vision to a child who is suffering something, and exactly not like a disease in other means there is no organic disorder. accept the things are not in focus. And as we know, and very well highlighted by you, sir, that whenever the visual deprivation of any sort, maybe in the clarity, focus, quality, they all affect. Particularly like where you said that Hyperopia or astigmatism, and when it becomes unequal in both eyes, it becomes very, very important. As we all know, a healthy visual maturation requires a correction of refractive errors. That means sometime Ametropia or Anisometropia in children. Besides something as a organic disorder. If it is not there, only it is a error related to the refractive errors, they need to be addressed as soon as possible. Though there are many things like a congenital cataract or developmental cataract, they also need early surgery. And that also can be used as a one tool to improve the vision. We all know that high refractive errors, because of their quality of poor vision in the child's mind, have a significant impact on his learning and in his social behavior. Because what all he sees is being grasped, what all he sees is being reacted, and the way he reacts, that only decides that what he will do or what somebody can think of in doing as a development. So there are many indications. I will just elaborate a very few. And but with
Sorry
the
to
common
interrupt you, sir.
that-
Sorry to interrupt you, sir. The
Yes.
screen is not visible. The PPT is
screen
not
is-
visible.
Virendra, your PPT is not visible on the screen.
Sorry, so that is what I asked. I will
Are you-
share again.
You asked about audibility, that was there.
Okay. Okay. So should I share again?
Yeah.
Yeah.
Yes, sir. It is there now.
I hope it is visible now.
Yes, sir.
Yes.
Okay. So I will just go through the slides. I will not read in detail. So people who are listening, they will make a point. So this is where we are to start the refractive surgery in pediatric population as a second talk of this session. And as you know, the pediatric refractive surgery is not very common. The reasons are many, but it is required in cases where we are not able to give good refractive correction by common means of glasses, sometimes contact lenses. So whenever you are having problem with these, you are only left with something to do as a surgery. I have my own reservations for doing this. I hope now it is everything clear, the
Yes,
slide
yes,
and
yes.
audio. Okay,
Yeah.
thank you, sir. Thank you. So whenever there is a inability or intolerance to glasses or contact lenses, maybe because of some physical reason, mental reasons, or because of the quality of vision with the two different eyes, you have to choose something to make them near equal or the normal. Anisometropia is a very common indication, but when I said in the beginning that I have my own reservations for choosing any refractive surgery, as Dr. Shukla has very correctly and emphatically prompted out that proper cyclopedia to know the actual refractive error is the most important thing before you start doing some surgery. Giving wrong glasses, giving wrong contact lenses is easily reversible, correctable. But doing a refractive surgery in a child may not be reversible the way we want. So we should be very, very concerned about doing proper cyclopedia, correcting it, checking it again and again, and then only jumping into decision to correct it. Our aim is to develop optimal binocular vision. That is the most important thing. And elimination of anisocleria or anisometropia or high hyperopia, because they all have impact on visual development, mental development, binocular vision, the fusion, hysteropsis, and many other things. And you know, the flexibility of this development is there in very early age only. As the age progresses, this becomes difficult to achieve. You may have two aligned eyes looking no astigmatism, but there may not be any fusion. And as I said in the beginning, because of some reasons that patient is not cooperative or not able to wear glasses like autism, cerebral palsy, Down syndrome, or some compliance issues in occlusion therapy, more so because of the nuclear family development. Both parents are very busy, and the social reasons that we are moving very often now socially, and it is difficult to have the compliance in a social times. And because of this, it becomes very poor compliance in other time also. And I feel still personally, I think Dr. Shukla sir will also agree that occlusion therapy is the most important thing in correcting ametropia. It as a treatment, mainstay of the treatment for amblyopia, and the results are very, very good. Though there are differences, people are doing part-time occlusion or full-time occlusion, or they are doing kind of occlusion by atopenization or something else. We are not going into that detail, but we know that giving equal chance to both eyes in early age actually makes the difference. And that is why sometimes you require or you resort to something like refractive surgery correction, because our aim is to equalization of visual input in both eyes, thus avoiding favoring one eye for developing and preventing other eye to develop. And just by improving the quality of visual input significantly in both eyes or in one eye, wherever it is required, will make the big difference. There are many options which are commonly, you all know, are laser refractive correction surgery. They can be implantable lenses in a normal eye. These are phakic lenses, or there can be a refractive lens exchange. There are so many controversies around each. So I will just discuss in brief, and then we would like to have an interaction or question answer if possible. LASIK is very, very popular surgery for adults. Very, very good results. Maybe it is a LASIK, femto LASIK, or a SMILE. They all are having very, very good results. Many millions have been done in India and abroad. Very fast recovery, as you all know. But the basic issue in LASIK, we do a flap creation and then refractive correction on the stroma. And in children, the flap may have many, many issues. The child may not be very cooperative to prevent rubbing in an immediate post-op period. We have means to cover it. We can use cover. We can have protections, and protection wear will avoid it. The parents will take care, but still there can be issue. And we know the LASIK, sometimes the trauma causes issues with the flap. And if the flap reposition is not very good, again there is an issue. Post-op examination of the flap is also an issue because it is not very easy to do a slit lamp examination in a very early age. Though we are not going to do LASIK in 1 or 2 years of age, but even 5, 6 or 10 years of age also patient not allow slit lamp examination in a very comfortable manner. There are other issues which we'll cover with the LASIK and epi-LASIK or surface. The surface ablation has come out as a rescue to prevent the complications of LASIK in pediatric age gaze. In adult, we prefer LASIK if it is fit, but in children, we can go for surface ablation to avoid the complications of the flap. But now there are different sets of complications or problems we face. The main problem is that the children have a higher or better or a quick response of healing. And because of this, the corneal haze may be a big issue. We are doing this kind of surgery, maybe LASIK or surface, in an age which is usually not known for keratoconus. As we all know, keratoconus usually common in teens, and particularly in teens, late teens, around 15 plus. And we are doing this kind of refractive surgery at the age of less than 10, less than 5, or anything less than, in which keratoconus may be diagnosed by the usually available tools of topography, thickness, and other issues, which are not very comfortable. And it is very difficult to have actual topography, actual pentagram, or Scheimpflug imaging, or some other imaging tools we do before doing LASIK. Just doing ultrasound sonography as a common tool is not advised nowadays, because that may miss the actual thinned out part, and not doing topography or not doing Scheimpflug imaging may actually miss that form first keratoconus, because just by having a keratometry of 40, 45, which we think is normal in majority of the patient, may not be normal in future. So that is one big issue against the laser refractive surgery. There are so many other issues also which we will discuss in time. So healing is common, haze is common, and if there is a significant haze, it will affect the quality of vision. It will again have the refractive error coming to the previous stage, means pre-refractive surgery stage. So that also is an issue. Then you need to do a parents counseling, because when we do LASIK in adult patient, our aim and our success is depending on that getting rid of glasses, and that we are able to achieve in majority. Very rarely we need to say to the patient that you may not be having a full correction with the LASIK because of some parameters. We are doing under correction, and that is accepted because the patient is also understanding, parents are also understanding. But in case of children, the issue is that full correction is usually not achieved, may not be required also is one reason, because the other eye may be having some refractive error, so we want to make equalization. The number is going to change or may change definitely over the period of time, and there is no fixed rule that how patient will progress. Means we can't do overcorrection by any means, and sooner or later the patient may again have a high ametropia or high anisometropia. We have seen many patients in whom anisometropia is there since the age of 2, 3, 4 years. The gap is increasing over the time. It is not maintained same. Means what I mean to say, the elongation of eye usually is more in a already elongated eye, or sometime the smaller eye remains further small. But majority of the hypermetropia try to achieve emmetropization, as Dr. Shukla sir has already pointed out. In majority of the patients, in early age it happens, but that age we are not going to do a refractive surgery. Means less than 2, 3 years of age, it is a aim for emmetropization, but in later age it is not so. So the difference may keep on increasing and the purpose may fail. The role of postoperative follow-ups is very, very important because you require a frequent follow-up. You need to use steroids which have different complications like a glaucoma, cataract, or some issues with the surface also. Though not very common, but it can be there. And to have particularly good results in surface ablations, you need to give steroids for a longer period and maybe in more frequent doses also. So there is a definite role which patient should understand, parents should understand in this case, because the child is not going to understand. The role of glasses, amblyopia therapy, even after correction may be required, because as I said, it may not be fully correctable. The big issue will come that the amount of refractive error we want to correct is not possible in majority of the patient, because usually 1, 2, 3 diopter of plus or minus hypermetropia or myopia is not a big concern for us, even if patient is not ready or not compliant or not able to wear glasses or contact lenses. Because doing this refractive surgery for a very low correction is not a common thing. Even the patient's parent will not understand and may not do it, and we will not get the support from our colleagues also, because usually when you say that you need to do some refractive surgery in a very small child, they will take second or third opinion. And 90% plus of the ophthalmologists, for the good reason also, will prevent doing refractive surgery. And with the confusion, patients' counseling becomes much more difficult. Another set of problem is that in adults, we do refractive surgery in local anesthesia, topical anesthesia, and patient cooperation is required. And you all must be aware about it, that refractive surgery by laser, the most important point for good correction in quality and refractive amount is a centration of the treatment over the cornea. If it is not centered, you are not going to achieve what actually you are aiming. And if you do a decentered ablations, the quality of vision is a big compromise. And if you do a small correction, the cornea is having enough thickness. But if you need to do a higher ablations, then you are going to compromise something on the cornea or on the optical zone of the laser ablation. When you reduce the optical zone, you start some set of problems, particularly that regression is very common, very fast. The quality of vision is a big compromise, and condition of vision in the night is really, really affecting patients' capability also. Iris registration, which we commonly now use in adult patients, is not possible, because for iris registration, you need to have one image preoperatively, which will be used during surgery. And cyclotorsion after general anesthesia is a big issue. The big issue is that adult patients are cooperating by maintaining their vision at a visual axis. Means they keen focus on a visual axis. The target is there in the laser, and when they see in that target point, the corrections are done on a visual axis, which are actually required. But patient under anesthesia, the eye will roll up or eye will be decentered. So you need to pull it, and whenever you pull it, actually what happens, the cornea gets some indentations, some folds, and laser is going to ablate according to that. So the some folds will be deeper in focus, or some part will be superior to the actual focus, and they will have a different energy delivery, and they will not achieve the way we want the profile of the cornea for correction of the refractive error. Though there are few reports in which they have done laser ablations, particularly for photorefractive keratectomy or a surface ablation. Less reports are for LASIK, more reports are for sublaser ablation. But the number of cases done are very few, and they are also of the opinion that it is not a sufficient study to say that this should be done, but they can be tried. And definitely we as a refractive surgery group are thinking that can we prepare some guidelines which can be used for doing it for more often for good results. But again, I said there are so many issues which I will discuss, that doing surgery in children, even in the review articles, the line given is the glasses first whenever possible. So it means they also are not in favor of doing refractive surgery. But definitely when you feel that nothing is working and child is going amblyopia, of a deep amblyopia, which we can consider in other terms like a blind eye, because as we all know, the vision less than 660 is not very useful even for social reasons. There is a one good article in the Journal of Cataract Surgery for LASIK, but there were definite issues raised by Dr. Vajpayee from All India Institute of Medical Sciences that these LASIKs should be avoided for the many reasons. The common ones are that we are not very sure about the refractive error. We are not very sure that refractive error, how frequently or how fast it will change. There is a decrease in the contrast sensitivity, more so when we are going to do a high refractive corrections. Persistence of amblyopigenic stimulus, which we want to remove, may not be removed because of the poor quality of vision if achieved later. And as the patient was not ready to wear glasses before, if he is still left with significant refractive error, or soon the significant effect comes in, like within 1 or 2 years, and patient is still in amblyopigenic age, the purpose will be lost. Nobody is sure about the long-term favorable outcome of these LASIK in an early age. And one important thing, as I said, that the keratoconus in whom will develop, still we don't know in an early age. So that is another issue. The second issue is that when we give some surgery and still there is a significant amount of refractive left over, we can't do a second surgery in these patients so often. And as I said in the beginning, that the haze is very common, and because of haze, quality decreases, quantity decreases, and refractive error comes back. And because of some haze, what actually happens is that light is not actually entering the way we want, because some areas will have haze, not all areas will have haze. So that is also a big issue. It is rarely visible on torchlight, but on slit lamp examination it is visible. You can use antimitotics, you can use steroids, but in a very limited and safe manner only. In adults, we are more comfortable in using these things. The another options are, as I said in the beginning, that you can have a phakic lens as a choice. But the big problem in these children again is because the basics of phakic lens, the sizing is the most important thing which will decide that patient will have complication or no complication, as well as refractive correction. The biggest advantage of phakic lens is that you can actually correct high refractive errors. But unfortunately, it is more so only for myopia. For hypermetropia, it is going to be a big problem in high refractive errors, because in high hypermetropia, usually eyes are smaller. And because of that, we are not going to have enough anterior chamber depth, because for ICL, ideally the anterior chamber depth should be 3 millimeter, which is not achievable in most of the hypermetropia. There can be complications like cataract or glaucoma because of the lens implantation surgery itself, or reaction because of the touch in the either iris or on the lens. The advantage of phakic lens is that it is reversible almost fully, because you implant and you remove, the same refractive error will come back. But we are not very sure that how the sizing of the eye will change. It is difficult to measure actual white to white. If you are not able to measure actual white to white, then ICL will be undersized or oversized, and both are having a big problem. So that is the issue. Another issue which we advise patient of all phakic lenses not to rub eyes anytime, forever, which we can't explain to the child very significantly to have that he will not rub. So that also is a big issue, and it can create complications. Refractive lens exchange, I am just putting it. I am not in favor of this by any means. Though we are doing a lot of pediatric cataracts, and the pediatric cataracts are not having problem like what I am going to narrate. But we all know that doing refractive lens exchange, even in the adults or middle age, we are seeing complications, particularly for myopic refractive lens exchange. So the issues with the refractive lens exchange, again, IOL power calculation to the accuracy is a must. We have handheld keratometers. We can do axial length measurement by ultrasound, immersion ultrasound under anesthesia, but still the refractive power calculation is an issue, because we have different thoughts that should be reduced 20%, 10%, or what amount of power should be implanted lower than that. As Dr. Shukla sir already pointed out, there are so many patients goes for emetropia, but there are some patients who never go for emetropia. So if you leave undercorrected refractive error, particularly for hypermetropia, they may maintain high refractive error even after refractive lens exchange. And for myopia, there are different sets of problems, so that is usually avoided. So you can think, if you are thinking for myopia, think for phakic lens. If you are thinking for hypermetropia, think of refractive lens exchange. Loss of accommodation is also going to have a very negative impact on development of a child, particularly for amblyopia, for his lifestyle, because accommodation is a big advantage after correcting one part of refractive error. We can't think of doing multifocal, trifocal, or any kind of multifocality lenses like accommodative or something in a children, because of different sets of problem of maintaining the centration of IOL, posterior capsular opacification. If you do a YAG, that is a problem. If you do a posterior capsulotomy during the primary surgery, there is a problem for maintaining the centration. The another issue is that what all capsule you leave for implanting the IOL, that can have an unequal fibrosis, and because of that also the centration is an issue. The vitreous thirst created during surgery, immediately after surgery, can also cause an issue with the centration. When you apply sutures, they have their own effect for astigmatism and the quality of vision, which may be left over. As very important that if you don't correct astigmatism, that is a big issue. Implanting a toric lens of a multifocal nature, and you know the axis of the astigmatism keep on changing from vertical to horizontal, which will also have an issue. So there are so many issues, and you are only left with the monofocal lenses. And if you do monofocal lens, the accommodation is lost. So you are trying to achieve one thing, you are at the cost of one big thing. Accommodation is a big reason that the children will develop good vision, and particularly for the mental development, it is a required thing. And postoperative issues you all know, so I'm not going to details. Though they are not very common, but if they are there, they are going to have a big problem in your success. Routinely, we don't do a pediatric LASIK. There is a common dictum. We can do some other surgeries, but still refrain. The thing is that when you think of doing surgeries, you actually don't put your own efforts to correct amblyopia or use glasses or contact lenses as a primary tool. Because we as a surgeon try to do a surgeries more often in adults, but for children, it should be reverse. You should try to do glasses, contact lenses, do counseling, again and again counseling, put extra effort, give extra chair time, give time to the child also. Many child don't understand, but when you give time, they understand. So my take home message that it should be the last resort. classes consultations should be tried. The patient counseling and parents counseling, both are very, very important. I don't ignore children during counseling. There are many parents, they want their children should go out when you are discussing. I say them that I will discuss something which is really required for a child. And if I require to tell something which is very negative, that time only I say that you come again or call me on phone or something. So then we can have a separate session in which child does not know that something is being discussed as a hidden. Because when he have a curiosity that something was told to me, something is not told to me, he still have a negative mindset.
Now,
Negative mindset, there is a
sum up
problem.
because we have to have some time for
Just last slide, sir. So if at all to be chosen, surface ablation can be chosen as a better option. Importance of follow-up is very, very important. The lens implantation like phakic or RLE should also be taken on a backseat. Thank you very much, sir.
Thank you very, very extensively. You have elaborated, the refractive surgery in children. Of course, there are many concerns, but nowadays, as even people of 60 years in the Western world are going for LASIK. I mean, even
Yes.
ladies are 60. But in children, we have a lot of concerns. We all know about it. Now, this is open to questions. If anybody want to ask any questions, Swapnil.
Yes, sir.
Yeah, please
So we are
open it.
open for discussion, and we are also open for questions if there are
Yes.
any. We
Like to have some,
questions
because
for
since it is an instruction course, where the questions are welcome. We like to have how much the people have understood both these lectures. Both have been talks have been very comprehensively. I think they have been delivered. So any questions anybody would like to ask? Any concerns? Any comment?
You can either unmute yourself or you can write it in the chat. We can take up the questions in that way also.
No, let it be open. People are there on the they can ask on this platform.
Meanwhile, somebody asked, can I ask one question to you, sir?
Me? Yes, please.
Yeah. Sir, there are questions, or commonly people are still not using occlusion. So what is your take on this? That should you do something that most of the ophthalmologists start using occlusion, and they should create a positive vibrations in the parents' mind that occlusion is very, very important for amblyopia treatment or prevention.
Occlusion now is a different subject. Amblyopia, it will come in the amblyopia. But there's been a lot of pedic studies bhi bahut sari hui hain, and now there is a change in the paradigm of occlusion also. We're starting with 2 hours, 6 hours, and then up to 12 hours. But of course, the treatment of amblyopia is still the gold standard is still occlusion. There is no doubt about it. But there are a lot of parameters: mild, moderate, severe amblyopia. In mild amblyopia, usually, we start with only 2 hours of occlusion to begin with, and then we see for about 6 weeks, which is the standard way of seeing. And if there is any improvement, then we continue with that. If there is no improvement, we switch on to 6 hours of this thing. More than 6 hours in moderate amblyopia is not required. But if the amblyopia is moderate or severe, means more than 636 or 660, then of course there is no shortcut than a full-time occlusion, almost about 10 to 12 hours. Full-time occlusion, then also alternate day. Now we have the binocular therapy also now, which we are doing. And we have a lot of gadgets now, not available in India, but at least the importance of viewing TV is also one of the we are stimulating the binocular vision, because now it has been also found that the suppression of the bad eye by the good eye, because of the binocular, we have 60% binocular cells in the eye. So those binocular cells are also, they are subdued because of the amblyopia. So we want to stimulate those binocular cells also to treat uniocular amblyopia also. So that the basic aim is that not only the uniocular vision should improve, but also the stereopsis should also improve. after amblyopia treatment, and that stereopsis and fusion will only improve when you treat the binocular, stimulate the binocular cells also. So that is not the dichoptic therapy system which is now in vogue is also that. But of course, there is no shortcut from treatment amblyopia. But then there are in the refractive errors, we all know that how much to treat is a different subject after all. But especially in cases of like you have a unilateral cataract and you're not able to operate at least by 2 years or 3 years of age, then you must occlude at least for 2 hours per day the good eye so that the cataractous eye would receive at least some light, some development of the retina. And we are not concerned with the retina. Retina is only mildly affected, but the visual cortex is affected. Main is that. Any questions? Any questions from the audience?
The one more thing I want to highlight particularly is that in children, the glasses should be of proper size. They should be properly placed. There are many of the children I have seen, they are wearing glasses which are having a flat top. Flat top means the nasal bridge is at the upper margin of the glasses. And because of this, their field is restricted, or very often they see above the glasses. So
there are many problems, and unfortunately the biggest point is that the ophthalmologist does not deliver anything about the type of glasses should be used. Myopia is different, hypermetropia. That's why in my book of management of refractive errors and spectacle correction, lot of emphasis has been given on proper spectacle wearing also, and that we leave it to the optometrist, and he plays all sort of according to his because the more the payment
just for the benefit we are discussing how the glasses should be made.
जो glasses बच्चे को पसंद आते हैं और माँ बाप को सस्ते पड़ते हैं वो दे दिया जाता है. You see, the most unfortunate thing is this. So the doctor should also explain to the patient what type of glasses should be given.
Similarly, the centration should always be checked by ophthalmologist once glasses are made, because high refractive errors, if they are not properly centered, they will have prismatic effect, and because of that prismatic effect, either they develop
any refractive
will not have fusion.
Of course, any refractive more than 5 has prismatic effect. So not only the centering, even the size of the glasses is very important. The larger the size, the more the prismatic effect, because the child has to look more down, and the myopic glasses are thicker in the periphery. So they act as concave. That concave lens acts as a prism with a base down. This thing. So all those sort of problems are there. But I think 99% of ophthalmologists will not describe anything to the parent what type of glasses. So
should be that aberration should be looked after during glasses and for surgeries. And if it is being not done, then there is going to be a problem. And Dr. Shukla sir has really pointed out that all the patients, pediatric cataract, I would like to say particularly of my interest, should be addressed at the earliest, rather than doing the dilation, cyclopesia, or avoiding one eye or other eye. The surgery should be done as a immediate basis. May not be implanting IOL in a very small child, but now we are implanting IOL in majority less than 1 year, and some patients even 6 months plus also we are implanting IOL without any complication and problem. So I think the pediatric cataract need to be given urgent care, and there should not be any doubt that let the child grow, because the common word we hear is that let the child grow, we'll see after a few months, and because of that only the patient keep on waiting rather than few months, few years, and that becomes a big problem that goes into a deep amblyopia.
So Swapnil, do you want that we should stop here, or we should continue for the whole day?
No, we require left with 2 minutes only. After 2 minutes, she will stop us.
Acha, so
I would be glad, sir, to make you talk for the whole day. But yes, we have the other speakers as well. But we were really very happy to have such an extensive presentation from both of you. And I understand that you also covered up for the 2 people who weren't there. I'm glad for that, sir.
That is my responsibility, what to do, if they don't come.
Correct.
Anyway, so
just before we wrap it up, have we taken the question which is on the forum?
I didn't see any questions. I don't know.
Yes,
Yeah, if
sir,
you
I will
have,
just
you
guide you through it. So it's by Dr. B.S. Goel. Very good presentations. What's the comment on if we had only option of LASIK correction, and someone invents glasses, should be given a Nobel Prize? So that is what.
Sir, Nobel Prize is a good,
मैं समझा नहीं क्या
but there are two different things. We can't have two things together. That is the issue.
Okay.
But really good to see that you are listening this
Dr.
pediatric
Goel is here.
session, and you are the stalwart in this pediatric ophthalmology in India, and your devotion and dedication is well known.
He can come on the
Thank you, sir.
screen, Dr. B.S. Goel, sir.
I don't know. I cannot see him as of now.
But I hope we have answered this question.
Yes, sir. Yes, sir.
Any other
Thank you
thing,
so much.
question?
No other questions, sir. It's all.
So
So
thank you,
we-
Swapnil, for being with us for this session. And
Thank you
I'm
so much,
really
my
obliged
pleasure.
to be with session Dr. Shukla, sir. He is my teacher and devoted pediatric ophthalmologist.
We have, I should not blow my own trumpet, but I've been doing pediatrics for a long time, being secretary also was there, and doctor of the pediatric ophthalmology, written books on pediatric ophthalmology. I have 2 more books anyway, but the other one is Dr. Virendra here. He is the #1 in LASIK in this country,
Oh.
and the pioneer of LASIK in this country, I should say, yes.
No,
And
no,
so
sir.
it
Only in
was,
state.
so I wanted him to be here because you see the LASIK in children is a very, very controversial topic, very, very controversial.
Correct.
And as we are advancing in pediatric ophthalmology, because a child which loses his vision in early childhood is lost forever, is lost for his whole life. So that's why we have to find out ways and means to correct vision as early as possible in the best possible way. So LASIK was one of the things which was not there. So we close this session now. Thank you very much to everybody, and to you and Virendra also. Bye bye.
Thank you, sir.
Thank you, sir. Thank you. Have a great day.